Just video. Video is playing?
Yes, sir. Yes.
Very
Nice.
well.
Very nice.
And then we'll start.
Yes, sir.
Good evening. I welcome you all to the 6th webinar of 23-24 of MCNS. For today, we have a very interesting topic, the surgery for the colloid cyst. I distinctly remember when I was undergoing my MCS training, the book by Apuzui came for the third ventricular surgeries. Today, we have Dr. Varun.
What has happened here? Let's see.
Kartikar sir, your voice is cracking. Can you?
So I welcome you all to the feast, an academic feast of
Stop for
Recording in progress.
right.
What has
Dr.
happened?
Chandan.
Yes, sir. So, good evening, everyone, for this today's topic of colloid cyst, how I do it. So today we have three eminent speakers with us, Professor Varnan Bello, Dr. Shivshankar, and Dr. Subodh Raju. We have our eminent panelists today, Dr. Sunil Shah, Head of Department, Bombay Hospital Neurosurgery, and Dr. Kishore Chaudhary from Sheffield Hospital, UK. Varnan sir, should I ask Shivshankar to start his presentation if you need some couple of minutes?
I think it's better.
Yeah, okay. So I'll hand over the proceedings to the panelists. Dr. Sunil Shah, we'll start with the first speaker. Dr. Shivshankar, you can start with your slides.
Yeah, is it seen now?
Yes.
Good evening, everyone. I'm here to share this topic of transcortical approach for the colloid cyst. I was supposed to follow Varnan Bello sir, and this is my turn now. So just to give the overview and pathoanatomy, colloid cysts are benign lesions that arise from the anterior third ventricle, located at the very complex location of foramen of Monro. And we need to know very important anatomy around the foramen of Monro so that we can plan the approaches and even corridors. We should know the anatomy of the thalamus-right vein, septal vein, interseptal vein, colloid plexus, and the columns of fornix and thalamus. So once we know this, then we can plan the approaches as per the knowledge of the anatomy and the experience with the whatever approaches we choose. Either it is endoscopic when we have the infrastructure and experience, and when we choose the microsurgical that most of the neurosurgeons we do, that is either we go transcortical or transcallosal, and we either go use two corridors, transforaminal when the lesion is in the foramen, and we can approach it and dissect it around once we evacuate the content of the colloid cyst, and transseptal when the lesion is very big and it is pushing down the fornix and even the foramen Monro. And in that scenario, we have to go to transseptally. This can either be reached transcortical open or endoscopic also. So for this, any approach, we have to have this knowledge about the anatomy about the ventricles, and mainly when we see the veins in the, once we enter the ventricle, we see all these veins and they guide us to the foramen Monro. Mainly we should know the anterseptal vein, which is in the midline and over the septum, and thermostrate vein and anterseptal, they join into the interseptal vein. And posteriorly, along the choroid plexus, the superior choroidal vein drains into the anterseptal vein. So foramen Monro is exactly in front of all these joining, and even the choroid plexus joins there, and just above the choroid plexus is the body of fornix. And fornix forms the roof and anterior part of the Monro on both the sides. So once in the ventricle, once we are going transforaminally, we usually see one foramen, and once we are transseptal or transcallosal, we see both the foramens. And we have to have the orientation because at depth we lose the orientation mainly in the ventricles. So this anatomy about the foramen of Monro, veins, and the thalamus, the septum, we should be aware because any damage to the fornices will cause a severe memory loss, and even the damage to the veins have a high morbidity. So we also should have the endoscopic anatomy, and when we put the endoscope, how the things look, and mainly these veins guide to the foramen Monro and the choroid plexus, which take us to the Monro. And when the choroid cyst is in the at the region of Monro, and how the anatomy has altered, also we should be able to understand. So we need to study the radiological images properly, so that we know that where the colloid cyst is located, because colloid cyst can be located at three different regions. Most common that we all see is anterior one, and there are even a few cases of posterior located colloid cysts are seen. And we should know that how the colloid cyst has displaced the local anatomy. In that scenario, we should know that the fornices, relation to the fornices and relation to the veins and foramen Monro. In this case, a very large colloid cyst you can see here. In that, the foramina has been pushed down, and in this scenario, it's difficult to go into the foramen and take out the cyst. And we need to take out the septum and go in and drain this colloid cyst and excise. And in this case, we should be aware of the anatomy of the fornices here. So we use, as I told, two corridors, either transforaminal, transseptal, and transcallosal is other thing. And when the cyst wall is clear and small and it is completely visualized, it can very well be taken through transforaminal approach. And when the cyst is large and active the foramen Monro and growing superiorly within the leaflets of septum pellucidum, and rendering this wall is inaccessible transforaminally, and we have to choose a transseptal. So when we go transeptally, this is what we can see, that we have to see that this is the choroid plexus here, this is a fornix, and this is the septum where we open, so that we can see the anatomy on the ipsilateral side, and through this we can see the anatomy on the opposite side. And if the large choroid cyst is there, we can evacuate and dissect the cyst wall gradually. So coming to endoscopic versus transcortical, endoscopic will be very well spoken by Subodh Raju sir. And for endoscopic, we require it is very minimally invasive, and it is a standard of practice at present. And the incision is around 3 centimeter, and burr hole might be around 1.5 centimeter for endoscopic approach. And seed diameter is usually allotted as 7 millimeter for corticectomy. And for craniotomy, what we usually do is a mini craniotomy, wherein we extend the incision in case of required to 5 to 6 centimeters, and 3 centimeter mini craniotomy with the 1 to 1.5 centimeter corticectomy we'll do in this case. So how I do it mainly in transcallosal. What I do is because I have an endoscope at my setup and I use the endoscope in the beginning. So transcortical approach to the colloid cyst. In actual sense, even both endoscopic is transcortical, because both in procedure of endoscopic versus open, we need to hit the ventricle and go through the cortex, then we can reach the ventricles. So I usually do a hybrid approach, wherein I start with the endoscope. Once I do a corticectomy and hit the ventricle, and we dilate with the dilator, and then we put the endoscope and then see the anatomy and evacuate the content, and then dissect the cyst wall. And if it is very well taken endoscopically, we will take it out. And if it's not possible, and I feel that difficult anatomy, then I take the microscope to excise the wall around. So as endoscope is minimally invasive, and once contents are evacuated, cyst wall is easily mobilized to excise. Once we master the skill of dissection of cyst and excise it completely using endoscope, I think that is the optimal way of treating colloid cyst. Whatever may the approach, the purpose is minimal damage to the surrounding brain structures and excising completely the colloid cyst. As I told, we use endoscope in the first attempt when we enter the ventricle and see the anatomy and evacuate the content. And if it is possible to evacuate and excise endoscopically, we finish the case in endoscopically, or else we evacuate the content and dissect it under microscope and excise the content cyst wall completely without damaging surrounding vital structures. So endoscope gives us a funnel vision, and through an narrow corridor we can take out the tumor and cyst wall also. But limited bimanual dissection in deeper structures is difficult to begin with, and hope we can master it over a period of time. So when lesion is large and complex to dissect sac from surrounding structures, we extend the same incision of the burr hole that we make around 3 centimeters and convert it into a small craniotomy of around 3.3 centimeters, 3 to 3 centimeters. And corticectomy size remains the same as we introduce the endoscope. The same we pass the linear retractors to retract, and we need craniotomy because we cannot apply the linear retractor through the burr hole what we make. And we need craniotomy only to apply the retractors for depth vision, so that surrounding brain which falls into the tract and obstructs the view will be prevented. So retracts can be adjusted as per the direction of vision we want during dissection. And being all neurosurgeons happy with the microscopes, we are very comfortable with this microscopic dissection. So in both traditional craniotomy and endoscopic craniotomy, the evacuation of the content of the cyst is important, and then wall is resected gradually. So either these approaches can yield complete resection and give us a cure, and hydrocephalus is usually taken care once we take out the cyst completely and resect the cyst wall. Shunt is usually not required. So coming to the present index case, that video I'm showing, he's a 36-year-old male who presented to us with acute onset, gradually progressive raised ICP headache with multiple episodes of vomiting of one day. And he developed recurrent episodes of hydrocephalic attack last 2 hours before presenting us. And when he presented us, he was drowsy, not awake, and pupils were equal. There was a bradycardia. Still, he was moving all 4 limbs. So this is a video that I'll be showing here. Yeah, this is a case of colloid cyst here. You can see the colloid cyst. It is quite large, and this colloid cyst, yeah. So this colloid cyst was anterior near the form of Monroe, and we should be aware of this anatomy with the fornices here. You can see the fornices anteriorly placed, and it was severely compressing the form Monroe and patient had, and you can see that this particular this colloid cyst is well above the fornices, coming into the septum in the interseptal region. This is a classical colloid cyst. You can see that high proteinous material scan also. So this is lifting both the fornices up. Hello, hello.
Yes.
Yeah, am I audible?
Yeah, you're audible. Your video is not seen now.
Yeah, even I'm not.
Screen has become white. You can play the video separately from the player if it's not playing in the PPT.
Yes, I'll do that. Is it seen now?
No,
Is my video playing now?
no. You're not yet shared the screen.
Your screen sharing is stopped.
Yeah, yeah.
Yeah.
Is
Yeah,
it
It
seen now?
started.
Yeah.
Yes.
Play the video.
Yes.
Yes, I'm playing the video. This is what we see in the CT, and understanding the images, there is a very large colloid cyst, which is interseptal, which is playing both the fornices, and which is compressing the foramen of Monroe down, so that the approach through the foramen of Monroe is difficult. Am I seeing? Hello? Hello?
Yes.
Yes, sir.
We are seeing.
So either we can plan transseptal or transforaminal. Transcallosal will be difficult here because patient had presented acute with an hydrocephalic attack. So brain will be full and intramuscular approach will be difficult in this case. So we have to first put the EVD so that we drain the CSF, and then we can think of endoscopic. If it is possible, we can go ahead with the endoscopic approach, and we need to decide the side. It is usually right side, as we all know that is non-dominant hemisphere. And then we position the patient supine in the neutral position with head above the heart level. And then we have to plan the burr point as per the approach we are planning. It's a transeptal, we have to take it little lateral. So in this particular case, we has presented to us with the acute hydrocephalic attacks. We need to drain his CSF first, putting an EVD, and that we do once patient is positioned and under navigation guidance, we hit the ventricle and drain the CSF. And then transcortically, we go with the endoscope and see the anatomy of the ventricle. And then because as the tumor is quite big, colloid cyst is quite big and pushing down the foramen of Monro, so I had planned for transseptal corridor, and then endoscopically evac the contents of the cyst and dissect the cyst wall and excise it. So for me, it was quite difficult to go endoscopically and excise the cyst. So then I took a microscope and converted the small burr hole, in which I made an incision, skin incision around 3 centimeters. I extended around 1 centimeter anteriorly and posteriorly, and then converted the same burr hole, which was around 1.5 centimeter to 3 centimeter, and did a mini craniotomy. And using the same corticectomy, we applied the Deller retractor and went into the ventricle and excised the cyst wall gradually. So this is the position, supine, and then we mark the burr hole under navigation, and this is a skin incision what we made. And after that, once again, we confirm the direction of the burr hole and the site of the burr hole. As you know, there are in three locations the cyst can be there, and we plan accordingly the burr hole. So once burr hole is made, dura is coagulated, and it is opened in cruciate manner. We can see the brain is bulging out. It is at high pressure, and then we coagulate the pia, and using this navigation guided catheter, we hit the ventricle, and it was quite under high pressure. The CSF is drained under high pressure. This is how we entered the ventricle. It is very well be done without navigation also. So this is a high pressure CSF drained in this patient. Then we introduce the endoscope and try to understand the anatomy here. In the anatomy, you can see that the septum pelvium is quite bulging down, and I'm not able to see the foramen Monro there. I'm quite the colloid plexus, and anteriorly is the foramen Monro. And this was my plan since it is quite big. So I wanted to go transseptally in this case. So this is the colloid plexus here. This is the thalamostriate vein, antiseptal vein, foramen Monro here, and this is septum. This is a fornix, and I have to be aware of this fornix and then go through this point transseptally. So this is the septum I'm coagulating, that's the colloid plexus, and now we're seeing that this is what we see once the septum is open. Just coagulating and opening the septum here. This is the septal opening, and this is the fornix down here, and this is the colloid plexus, and this is the thalamostriate vein, antiseptal vein here, and this is the foramen Monro, which is pushed down by the large colloid cyst. This is the colloid cyst seen across the septal opening. So this is what we do as shown here in the diagram. This is the septum that has been opened, colloid plexus here, and then go ahead with the opposite side and evacuate the content. This is the content being evacuated endoscopically, and we can see the cyst wall there. This thin wall, but quite large was the cyst. So this is how we evacuate the content, and once content is evacuated, the cyst wall falls and it becomes easy for dissection. And this particular case had a lot of concretions, but solid concretions were there, which are not easily evacuated using this section here. And this is anatomy. Yeah, these are the concretions in the colloid cyst. That is a large cavity. After evacuating, you can see the quality very well, sac very well here. And then we gradually take out the cyst wall. I could not take it out endoscopically. Then I converted this into a craniotomy, extended incision, made around 5 centimeter incision. And that made the same hole I converted into a craniotomy. You can see this is the initial burr hole around 1.45 centimeter to 1.24. Then we did a craniotomy from 2.86 centimeter here. The same approach. Once the craniotomy is done, and this is the dura, we open the dura, and fix the dural edges. And this is the same cortisectomy that what we had utilized for the endoscopic approach. The same thing we'll be using for transcortical approach here. And through this, we need to retract the cortisectomy site so that I can see the phenomenon of Monroe and colloid cyst through the same cortisectomy. And once, you can see here that it is in line. The cortisectomy is in line with the anatomy what we're supposed to see. That is a cyst which is evacuated as a colloid cyst wall and fornix down there. And that was a septostomy that we did. And the last bit of concretions are being removed. The cyst wall has collapsed now. It is completely empty cyst. And gradually we dissect it off from the surrounding structures, coagulate it. And that is the fornix. We have to take care of the fornix here. We should not coagulate near the fornix. And then gradually we cut and should not pull at this moment of time because we have veins down on the opposite side, mainly the thalamus striate and septal vein and posterior the interseptal vein. So this is a cyst wall being resected gradually from the posterior point. We put the patty here and push it posteriorly and pull the cyst wall anteriorly. And gradually we can dissect it from the surrounding brain parenchyma, and you can see that that is opposite side vein there. Yeah, we should take care that we should not damage the vein. That is one of the attachment to the vein of the cyst wall from the vein, and that has been taken care. And there is a small separate cyst there, which is still remaining, which was not connected to the main cyst wall cavity. And this is the medial part of the dissection, and somewhere here is the fornix, and that is opposite side fornix. And I'm cutting the cyst wall near the ipsilateral fornix here on the right side and coagulating. This is opposite side choroid plexus, what you're seeing now. I'm coagulating it or separate cystic content there. And once that is done, and we gradually cut the cyst wall. Main dissection of the cyst wall is everything here because any remnant can cause a residue. So while dissecting cyst wall, we should take care that we should excise the wall completely, and we should not damage the fornices and the veins and thalamus down. So this is what makes the difference. As we, with the expertise, I think we can do it endoscopically. That will be very well shown to us by Dr. Subodh sir. And this is the last bit of the cyst wall being taken from the surrounding brain parenchyma. Because this is the vein. It is antecaudate vein there. Yes. Yeah. Without damaging much to the surrounding structures, we are able to dissect this cyst wall, and the complete lateral part of the cyst wall is completely taken out. And now this is the medial part attached to the fornix here. This is the vein we saw. And this is what exactly we are seeing in this video. This is across the septum. And this part was quite adherent to the ipsilateral fornix and even the vein there. And gradually we are coagulating and cutting and taking out the cyst wall completely. Yes, cyst wall is completely taken out, and there was a very small remnant of the wall which was adherent to the tightly attached to the fornix there. I could not take it out, very small remnant that has been coagulated. Here you can see the anatomy now. This is what we saw, both the foramen Monroe, both the choroid plexus and fornix, and all the surrounding vein. And in this case, since we did an emergency, I had placed the EVD, and this is the craniotomy that we did, and this is a post-op CT scan, shows that resolution of hydrocephalus and cyst has been completely taken, and that was a cortisectomy that we did, that is taken to the lateral ventricle. So this is the post-op CT scan. The patient did well, and he didn't have memory disturbances. Hello.
Yes,
Yes.
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 Okay.
Yeah. This is the video is done, sir, from my end.
Perfect.
I'll stop sharing the screen then.
Yes, yes. Sir, we'll take the questions at the end, discussions at the end of all the three talks. Varnan sir, are you ready, sir? With your...
Yeah, I'm ready.
Okay, sir. You can share your screen.
Yeah. Okay. Can you see it? Right.
Yes, sir.
I'm still having a problem sharing my.
We can see your slides, but it is
It's
not going into PPT
yeah,
mode.
It's sort of.
It is not. It is
Okay,
not
what
going into
you
the
do is,
PPT.
I think you take Subodh.
Yeah.
Okay.
The Vanan sir, what you can do is you just log out of Zoom and zoom in again
Yeah, that's
log
what.
in.
Yeah. Okay, I'll do that. Check out. Why not? Subodh.
Yeah. I'll start sharing this. Are you able to see?
Yes, yes.
Okay. Dr. Shiv Shankar did a lot of job of my transcortical approach. Basically, endoscopy approach is also a transcortical approach only.
Yes.
And these colloid cysts doing endoscopically, I've been doing it last 15 years actually. And I mean, my views are slightly maybe radical or contrary to what conventional thought is there. But let me quickly run through some of these. The introduction part has been told already. I'll not go into this. There's a colloid cyst risk score which is there available for everyone to know whether you should operate or not operate a colloid cyst. A very, very useful tool, I feel, for a practical in OPD and these things cases. And we should offer surgery. Then there are the risk zones 1, 2, and 3. 3 is the posterior, what he told about the 3, the posterior cyst, the anterior cyst, and the cyst in the middle, which carry a more risk and these things. And this is a paper which came out about endoscopic versus microsurgical resection, systemic review of 1270. This was published in World Neurosurgery. And as such, microsurgical is associated with complete resection and lower recurrence, but risk morbidity and these things were slightly higher in microsurgery versus endoscopy. You can see the mortality was low in endoscopy, the reoperation shunt dependency was low in endoscopy, the recurrence was higher in endoscopy. And these are all statistically significant. So these are a number of other papers which are available, things and they're telling that with more and more people started doing endoscopy, the things are maturing, the techniques are maturing, the surgeons are becoming more experienced, and their results are now becoming equally comparable to microsurgery in endoscopy. But again, this was about again a review article on that. Overall, it's a meta-analysis, morbidity and the mortality. It is as high as 19% morbidity in microsurgery versus endoscopy. And even the shunt dependency, venous infarct, seizures, infection in these cases. This is one of the cases which got referred to me for multiseptate hydrocephalus post colloid cyst excision. It was emergency in some hospital. They did a shunt and then they did a transcallosal excision. Unlucky for the patient, they landed in meningitis, and they came here for flexible endoscopic multiseptations for that actually. We see this, and there are a number of papers available. I'll not go into more into the details of this because these things are known that microsurgery gives a more radical excision than endoscopy. Complications are more in microsurgery compared to endoscopy. This is a basic fundamental of all the meta-analysis and all the comparative analysis which are available till date in the literature. And endoscopic approach also has a decreased rate of shunt dependency. That's also a very important thing. With newer endoscopes, we have superior illumination, magnification, and with angled endoscope, flexible endoscope, we are able to see the roof of the cyst. That's the most important thing which came with the flexible endoscope. The point of attachment of the colloid cyst. aiding in excision of this cyst. And this is by Framand, who told that endoscopic surgery shows similar rates of clinical outcomes as microsurgery. This is the article which I use, the grading system which I use for my personal thing for, I used it for my personal thing for deciding about the grade of resection of endoscopic whenever we are doing endoscopy. Grade 1, 2, 3, 4, and depending on the recurrences marked on these things. So coming to brief of the anatomy, Dr. Shivshankar already told it, but I'll show you the endoscopic anatomy of these things, because this is a basic anatomy which everyone should be, as juniors, should be familiar with. And this is the lateral ventricular anatomy, choroid plexus, a temporal horn. And this is the foramen of Monro, the fornix, the column of fornix, the septum here. And this is the internal capsule exactly opposite the foramen Monro, which is very, very important when the ventricles are not dilated too much. And this is the inside of the third ventricle. This is the floor of third ventricle, the infundibular recess, the general anatomy of the third ventricle. And I'm not going to the third ventriculostomy part. And so this is the view with the flexible endoscope, which we are seeing. Now what I'm doing is an endoscopic anatomy inside the third ventricle. This is the infundibular recess, that's the optic chiasma you saw. And as we come behind, this is the aqueduct which is closed. And this was basically a tectal plate glioma, but I'm showing it this for the sake of anatomy only. And this is the pineal recess, and these are the intracerebral veins. So a posterior located colloid cyst will be somewhere there, or attached there, near the intracerebral veins. Okay. So one more of these anatomy pictures. Besides this, the anatomy thing is there, and Dr. Shiva already told it about, already mentioned about it. But 2-3 points about the posterior part of the anatomy, which we are. These are the posterior commissure. This is the aqueduct, and this is the posterior part of this pineal recess and the intracerebral veins. So it's not question the intracerebral veins, because a long-standing colloid cyst with repeated may be densely adherent sometimes. So what we think about dissection and complete excision may not happen many times because of these things. We run the risk of injury in these cases. And this is optic chiasma and the other parts of the optic nerve and these things, ACOM complex of the third ventricle anatomy basically. That's an endoscopic view. This is how we see a colloid cyst when we do a correct trajectory. The septal vein, choroid plexus, thymostoid vein, this is the colloid cyst. This is how we see a classical case of these things. So, circumferential cyst wall dissection should not be the goal of the endoscope, as it does not necessarily result in better patient outcome. This is one of the literature which I have quoted. So the basic thing, I use the laser frequently. We have the thulium laser for doing the choroid plexus coagulation, opening up the cyst wall, fulguration of the cyst wall. So this is a step standard with any endoscopy surgeon does it. After they open it and they open the content. And when the cyst gets, the one additional thing I did is I open up the septum posteriorly. This part we open up the septum, and the cyst which is covered by the fornix can be easily seen in these cases. So, and we then from that side we evacuate the content of the cyst. Similar, one more case of same way, when the cyst is hidden completely, and after the content is evacuated, we excise the cyst wall, and so we do the we do a bimanual technique on these cases, holding the cyst wall and excising it, because you run the risk of bleeding. And at the end of every procedure of colloid cyst, we do a septostomy. That's mandatory. We see the opposite side for any bleeding, and inspection is done. And these are two endpoints of this cyst excisions actually. This is pre-op and post-op images of some of the cases. The colloid cyst, large colloid cyst, post-op. So endoscopy is effective in achieving gluteal in long-term control. And when we talk of the bimanual technique, which I was talking of, in where we can grasp the cyst wall with one, and with the other we can excise it. So this is a bimanual technique what we are showing here. So same way, we open the cyst, evacuate the content, and once we have evacuated the content, we hold the cyst wall with one and try to cut it. And every step of these small traction mobilizes the cyst, but we should not drag it too much, because you run the risk of bleeding, because the opposite choroid plexus might be adherent to the cyst wall. And in many cases, it is there. The scope is rotated. This rotation also helps in mobilizing the cyst wall. We take sometimes a blunt dissector to mobilize it, and sometimes we take the sharp dissection to cut the cyst wall circumferentially all round. This is the last bit attached to the choroid plexus. Once we slowly coagulate and cut, we keep on, it shrinks and pulls the cyst actually. And that's how we cut the cyst. And the coagulation can be bipolar, or you can use a laser nowadays. Another important thing in endoscopy is planning the trajectory. So this is a navigation guided passing an endoscope for the colloid cyst. So what we do is we place the the navigation probe inside the scope and give a trajectory and give a projection targeting the cyst. Because this is the most important step in colloid cyst, endoscopic colloid cyst. It's not the standard precoronal burr hole. The burr hole is placed much laterally and much anteriorly than the normal precoronal burr hole. And once we give the projection, and once we start introducing the endoscope, we keep on decreasing the projection. In this thing, you can see here, the projection is keeping on decreasing here. And so that our trajectory is maintained and we don't damage the caudate head. The caudate head is the main thing which comes on the way. So if you go through this method, we get a very good bird's eye view of the foramen of Monro. So this is the point which people miss. This is a ventricle is dilated, especially in relatively smaller ventricles. Using the endoscope is very, very helpful. And this is the view we get. The whole foramen of Monro looks flat to you. It's not oblique or anything. So the same way, the first step, as I told you, and we take the laser to cut and coagulate. The advantage of laser is it can cut and coagulate at the same time. You don't have to use your instruments repeatedly. And once we have the cyst wall becomes free and we have done enough of it, then what I do is I take this is the view of the flexible scope, and I look at the roof of this thing to see for any remnant of the cyst wall. So if anything is seen with the flexible scope, we fulgurate it. So after we fulgurate it, what it becomes a scab type of thing, coagulated material, which is easily removable. I mean, you don't have to really pull anything in these cases. Once you fulgurate it, it becomes dry and scab type of thing, and you can just remove it with the forceps. You don't have to do anything on that. That's the opposite side choroid plexus. You can coagulate that. So this is the thulium laser which we use, and at the end of that, we do a septostomy for that. And inspect the opposite side, everything is fine. That ends the part of the surgery. Same way, this is a large cyst which is present anteriorly. And same way, you get a beautiful view. If your trajectory is correct, your endoscopic view is fantastic. Same way, looking at this roof of these posteriorly, that's the main part which we miss it. You can see, once we coagulate it, you can easily take it out. You don't require to pull anything really. It is coagulated and scarred. It can easily be removed. So this is a technique which I've been using it from 2009-10 onwards, when I had first started using the flexible scopes. But now with the chip-on-tip, we are visualization, everything has improved a lot at these things. So this is a pre-op and the post-op of the same patient. You can see here, good follow-up remaining. And same way, one more case, similar cases. So I searched the literature. There is only one paper available for use of laser in the colloid cyst, and they have used the ND YAG laser, and their outcome has been good in these cases. Now comes some scenarios when you have an intraoperative bleeding. So this is a colloid cyst which we are looking at. So this is a scenario while doing endoscopy, you can land up in a bleeding scenario also, especially when you try to pull the cyst and try to mobilize the cyst. That can happen. So this is the same way, content being evacuated through an infant feeding tube under controlled suction. And after the suction is these things, we try to mobilize the cyst. So once we are mobilizing this, you can see it starts bleeding. So we wait with irrigation for some times. Then I immediately converted this into a dry field technique. We evacuated the CSF till the foramen of Monro, mobilized the cyst, because after you in an endoscopic thing, even a 3-4 ml of blood obliterates a vision. And as we all know that CSF is a very good anticoagulant. So we draw the cyst into this scope inside this, and we cut it and coagulate it with the laser only. There's a last part of the cyst which is mobilized, and then we irrigate it. After that excision has been done, we properly irrigate this or irrigate the cavity and do a septostomy. Inspect the opposite side for any hematoma, and that finishes the part of the excision. So these scenarios we can face sometimes when you are doing colloid cyst bleeding. This is one of the cases of a large colloid cyst, very thick tenacious material, where I did that same method, Dr. Shiv Shankar method, endoscopic assisted. It was not microscopic, but endoscopic assisted excision of the colloid cyst. Still, it had some remnant, but he was a 65-year-old gentleman, so we are just following it up in these cases. Similar, the small colloid cyst, a big challenge where the ventricle is not dilated too much is a big challenge in these cases. So now comes the part, I think we were, if Dr. Vernon would have done this, then I would have told this. There's a interesting article, Cognitive Function Assessment and Comparison on Lateral Ventricle Tumors Dissection by the frontal transcortical approach and the anterior transcallosal approach, respectively in children. It showed that IQ had no statistical difference in the task data, because previously study says that whenever you go for a transcortical approach, it impairs the perceptual reasoning and processing speed and IQ. But this was not in this article. And anterior transcallosal approach impairs patients' working memory and bit of IQ also, though both may damage IQ equally. And anterior transcallosal approaches in some conditions cannot replace a frontal transcortical approach, but it is, when we talk of vis-a-vis these things, so we can't tell that a transcallosal is better or a transcortical is better in these cases. But we should always remember protection of the cognitive function is the most important thing whenever we choose an approach in these cases. So this is my last case which I'll be showing. This is a straightforward looking colloid cyst. So we go from this middle frontal gyrus approach to the precoronal. 1 minute, play the video. Because here, what are we doing? What is the fader? So we are going through this SLF only, and after that we are directly inside the corona radiata and inside the ventricle. We have not disturbed any other fibers, white matter fiber, when you go from a transcortical approach. You can see this superior longitudinal fasciculus 2. That's a part which is getting damaged, and we run a simulation before the trajectory is planned, and look ahead the virtual in the navigation and the planned before we actually do that. And once we go inside, this is the anatomy which we see. You can see the foramen of honor, how it looks. It looks straight in front of you. This is all because of a correct trajectory. And these colloids, the choroid plexus is coagulated. The same way as I told you, we use this low current thulium laser. We are at this position now, right frontal horn and foramen of Monro. So slowly with the low current, we first coagulate it. If we are doing to cut it, we increase the current. But if we are just going to coagulate it, we go with the lower current settings. And then the cyst is opened, the content comes out, which is aspirated again by same way, infant feeding tube. And the whole, you can see the content getting sucked into the infant feeding tube. So evacuate as much content as much possible. It may appear that the cyst is collapsing. The third ventricle is started. We have started seeing the third ventricle, but we were not very happy with the size of the cyst and the amount of content. So what we did was we opened up the septum before the cyst excision only completion. We open up the septum pellucidum, and not sure about the vasculature because slight traction on that produced some bleeding. So I stopped there and opened up the septum pellucidum. So because the burr hole is very laterally, we can't go with a rigid scope to the opposite side and see the foramen of Monro. So we went into the opposite foramen. We were just able to see this. So what we did was we introduced the flexible scope through it, through the septostomy. And once we are into the opposite ventricle through a flexible scope, we see this colloid cyst here. So as if nothing has been done here. So what we did was we again coagulated the choroid plexus here, opened up the cyst here, and evacuated the content completely from the opposite side also. So basically we a type of disconnection of the choroid plexus from this side helped us in minimizing the bleeding. So this is the main culprit when you put traction on that. And once we did that, we came to the ipsilateral. This is the opposite side. You can see some of these. This is the choroid plexus only. But we thought that this could be a part of the cyst wall, so we kept on coagulating. So once we start coagulating the cyst wall, all the contents keep on coming out, and it forms. And this is the posterior part of the third ventricle. This is of aqueduct. This is a posterior commissure. Let's see this aqueduct. So this is the end point where we see all things, no hematoma, nothing, all clear. And the inside of the third ventricle is also clear. So basically going to the opposite side helped us in disconnecting decreasing the coagulating the choroid plexus helped us in disconnecting the colloid cyst, the choroid plexus from the colloid cyst actually. So, and this is possible only because of a flexible scope, because with the trajectory which we go, it's very difficult to go with a rigid scope into it. So I'll just, so this is another challenge what we face is these type of small colloid cysts which cause obstruction, because planning the trajectory is very important in these cases. These patients present with just simple multiple episodes of hydrocephalic attacks. They don't have persistent headaches. They present with small attacks actually, hydrocephalic attacks. Or so this a short experience of around 36 cases, and we had a extent of resection, that's an en bloc resection in 16 cases, and 14 cases we had complete cyst emptying with more than 50% coagulation, 3 and 4. EVD insertion was done in 2 cases. We had 2 recurrences, and our minimum follow-up is around, as of now, it's around 2 years. We have not taken the cases after 21, actually. We have done another 4, 5, 6 cases around, I think. And redo we have done. Loss to follow-up 2, 1 meningitis, 2 wound infection. None of the patients required a VP shunt. We had a memory deficit in 2 cases. This is our brief endoscopic data over a period of years. So concluding, endoscopic resection of third ventricular colloid is an effective procedure that provides total resection in most patients and has a low morbidity. Continuous training and evolving is necessary and remain the important factors in improving outcome. And when deciding on the modality of surgical treatment, one has to weigh the morbidity associated with radical surgical resection against a minimization of recurrence. So all these colloid cyst patients, I tell them that if the patient has a recurrence, I will again do an endoscopy and remove it only. The same way, because hardly any morbidity is there. And this debate still in the literature exists whether cyst remnant. There's some articles tell that it doesn't have any value, and some most of the articles tell that cyst remnants have a definite link to recurrence. But this is my short experience with colloid cyst. Post-operative MRI by itself not sensitive enough to predict recurrence, and that direct intraoperative inspection has the most accurate method to determine the extent of resection. In endoscopy, it is a possibility that the cyst wall remnant would be completely removed from where it is attached to the choroid plexus and internal cerebral vein in the roof of the third ventricle. And the last but not the least, the best procedure is one which can deliver the best result to the patient in the best experienced hand, in your own experienced hand. Thank you very much.
Thank you, sir. Varnan sir, are you ready with your? You're on mute, sir.
You're on mute, sir.
Unmute. Okay, can you hear me?
Yes, sir.
Okay. Mhm. Share the screen. Mhm.
Can you just enable screen sharing?
Screen sharing to be,
Just a moment.
yeah.
You should be able to do it now, sir.
You can share screen now.
Yeah, I'm sharing. Change the laptop also, the same thing is happening.
So we can't see your screen.
Yeah,
Just a minute.
we have changed the laptop also, same thing is happening.
Vanan sir, you are muted also. Dr. Vanan.
Oh, I'm not muted. It's not muted, sure.
Chandan, can you hear me? Hello.
Yes, sir. I can hear you. You are muted, sir. Yes, I unmuted you.
Maybe we can take some discussion or questions
Yeah, go ahead with that.
because it's taking time.
So, Kishore sir, Sunil sir, you had any questions or comments to the two presentations so far?
Yeah, I mean, the comment I want to make is that,
Okay.
can you hear me?
Yes, sir. Yes, sir.
I think the comment I want to make is that bimanual dissection of
Your
the cyst
charger.
is extremely important. Yeah. I mean, bimanual dissection of the cyst is the gold standard that we have been doing. Now, whether you can achieve that with a microscope or endoscope, that is each one's expertise. Because when the last part of the cyst is removed, there's always a bleeding vessel attached, right down into the third ventricle, which needs to be coagulated and cut. So I think bimanual the dissection is extremely important. That's my observation.
Kishore sir, any comments?
Yeah, can you hear me?
Yes, sir.
Yeah, actually, I agree with Sunil exactly. But there are a couple of things. We always talk about cornices and not damaging the thalamostrate vein and the septal veins, and the effects that it will have on the patient should we damage them inadvertently. And I fully agree with all those comments. There is no doubt about it. Our focus should be on that. But in my experience, whenever I've seen young neurosurgeons doing colloid cyst and having complications, I have noticed two complications that happen very frequently, mostly using a transcortical route, non-endoscopic route. One of them is, as Sunil pointed out, that you have evacuated the cyst, you are mobilizing the cyst. The cyst is like an empty milk bag which is trying to deliver itself out and trying to come out. And then you are in a rush to finish it off as quickly as possible and call it a day. And that is the time that you will have some hemorrhage, because at the end or the top of the third ventricle, there's always a vascular choroid plexus attachment to it. And that is the last attachment, often that gets severed with not much control on it, and patients get intraventricular hemorrhage. That's one thing. And second thing is, yes, that's fine. Hemorrhage can happen through colloid plexus or some of the wall of the colloid cyst. what I do, and I always say that hemorrhage bleeding has never worried me. It's where that blood goes always worries me, whether it's subarachnoid hemorrhage, aneurysm, or this case as well. So what I do is I always pack the ventricles, the virgin areas of the ventricles with patties. So whenever there is blood on it, you can always evacuate it very easily. And at the end of the day, you can wash out the ventricles and keep the ventricles as clean as possibly they can. And that's one of the reasons why patients end up needing shunt is because there's a lot of residual blood in the ventricular system, especially on the opposite side or in the third ventricle and going in the fourth ventricle. My comment about endoscopy is that I think it is still an evolving technique. It is promising. Those who are doing it for a number of years are able to do it much better. There is a steep learning curve for it. There is also a question of availability. These patients are not that common. So these are not like head injury cases. So how many colloid cysts you will do in a year? Ours is a very big center and we do only 2 a month. So probably an individual neurosurgeon is going to encounter maybe 1 or 2 cases in a year in an individual's practice. So you got to probably stick to what you're best at, whether it's endoscopic or whether it's a non-endoscopic route. But I find that with the availability of the instrument, the learning curves, and potential for not having enough cases to get an expertise on, I think for a routine neurosurgeon who's very comfortable with microsurgical techniques, I think non-endoscopic, microscopic excision of the colloid cyst will remain a very good technique for a foreseeable future. I think we will wait for Vernon to start with his transcallosal approach and then probably discuss it this all over again. Is that okay?
Can you see
Yes,
my
sir.
presentation? I think I'm
Yes, sir.
trying this for the
Yes,
third
sir.
time. Thank you, and sorry for the problems because there were some hard disk problems. So I think without wasting time, I'd like to thank the MCNS for this opportunity and also like to thank Chandan and Sunil and the gang for inviting me here. So what I'm going to do, I think most of the things are covered. So what I'm going to do is I'm going to concentrate on this elegant procedure, which is mostly used by us, especially in our department. And we have stopped actually doing endoscopy for colloid cysts. I'll tell you why. So again, I'm still in problems. My presentation is not moving. Okay. So this has already been discussed that colloid cysts, they're not very common. They are from around 2%. And the origin is still confusion. They say it comes from the front, comes from the top. So I will not go into detail. And the most problematic part is that the patient many times just has a subtle headache, or they come into you very unconscious and completely, GCS either 5 or 6. So there is no, these are the two spectrums which you will see and which we see during our practice. So the treatment, as we know, is conservative if they're very small. And if sometimes to save the life, you have to do a CSF diversion procedure. And the surgical is definitely microsurgical and endoscopic, as it is already discussed. And what we normally are doing here is that we see different types of cysts. We see large cysts, small cysts, and many times you'll have small cysts with bigger symptoms and large cysts with no symptoms at all. So it is the irony of this type of a colloid cyst. So the investigations, one point I want to highlight is when you are doing the MRI, also do the MR venography so that you know the pattern of the veins which you will come across. And I'm going to talk about the transcallosal approach because I enjoy this approach and I still do it. And in our department, we practice more of transcallosal approach. But however, when you're planning your incision, when you're planning your craniotomy, you always be ready for a transcortical approach because sometimes the veins can give you problems. So this is the basic position, what we use, a little bit of backup. Then we use a bicoronal flap, or also we use a half coronal flap. And it is a classical position which is used for all transcallosal, especially when you're working around the foramen of Monro. So it is different when you're going behind and if you're going to anterior. So this is the way how we position our patient, and that is the craniotomy. We do a slightly bigger craniotomy, not a mini craniotomy, because you got to be ready if you have to go transcortical. So these are the anatomy what one would see when you are going transcallosal. So you have to look for certain things starting from top to be down until you enter the ventricle. And once you enter the ventricle, the first thing is orientation. You have to know what is to the right. So thalamus right vein to the right means you are in the right foramen of Monro. If it is to the left, that means you are in the left. So this orientation is very, very important. And the advantages of this approach is, one, it gets you straight into the third ventricle. And I believe the microscope is the best because you can do a complete job. And this is the anatomy, what you would see. So going straight to the cases. Now, this is a cyst, which you see there is an altered signal intensity. You see are hyper intense and also see in hypo intense. So this is going to be pretty solid when you are going to be operating. And this is the way we do it, a classical transcallosal approach. During the previous years, we used to use the retractor. Now we don't use the retractor. So I'll show you what happens when there is a retractor around, because the retractor is the major cause for your damage to the vein, because you tend to retract more and more, and one vein gives way, and then all hell breaks loose. So if you see this, this is it is almost like pus. It is thick. The colloid is thick. So when the colloid cyst is thin, your endoscopy is going to work. But when your colloid cyst is thick like this, you're going to have a lot of struggle. And you see the choroid, choroid plexus is lining the colloid cyst. So you got to be dissecting it with both hands. You have to be disconnecting the vessels, which is very, very important. And what you have done here is you have sucked out all the colloid first, and then you are attacking the wall. In the endoscopy, all the irrigation, it lets all the colloid go here and there. You got to remove it in a complete one piece. We leave a drain for 48 hours and then we close. And that's the post-op scan of the patient. So this is another patient, a large colloid cyst like this. So we approach it transcallosal. A good ventricle it's very important to have a ventricle which is slightly large, because you can enter it much easier. So this is the position. We use a bicoronal flap here. Again, we are doing the ultrasound, and you see the colloid cyst beautifully. So you know exactly where to do the callosotomy. You need not do a big callosotomy. It's just a 1 to 1.2 centimeter callosotomy. Identify the pericallosal arteries, open the ventricle, and you can suck out the colloid material here, and then dissect it all around with both hands, rather than, because the more you coagulate, first you got to dissect it all around, and then you coagulate only the choroidal vessels, which are placed, mostly they are posterior inferior in the foramen there. That's the area where you get the vessels, where the choroid plexus enters the foramen of Monro from the lateral ventricles. So one need not coagulate too much, and you can beautifully see the anatomy. You can dissect it off the veins. Here we are not using retractors now. We are just using a silicone paddy, which helps you manipulate much better than if you had a retractor inside. Retractor takes in a lot of space. So sharp dissection and a gradual excision of the cyst in toto, which is very, very important. Otherwise, you can get a recurrence of these colloid cysts. So that's the tumor which is out in toto. So again, no retractors, and we keep a drain. That's the bone flap which we put back. That's the patient. Post-operative scan. This is another patient, again, a fairly hyperdense on CT scan. So these are going to be thick colloid. So the important thing is to go anterior to the coronal suture first, because that's the area where you will have less veins. Here what we are doing is we are putting marrow cell. We can put 2 blocks of marrow cell anteriorly and posteriorly to keep the hemisphere retracted. So you get space to work between the pericallosal, a small opening into the corpus callosum, and then one can enter. Sometimes the colloid cyst pushes the foramen Monro towards you. If you see here, this is not the right foramen Monro, it is the left foramen of Monro, and it has pushed the whole thing towards the surgeon. So we are getting a bit of decompression first. And this allows you to suck the colloid completely so that you're left only with the capsule rather than all the colloid going into the rest of the ventricle, which happens with when you're doing irrigation with endoscopy. So here again, no retractors we are just using a silicone paddy over the hemisphere. And then we are getting the colloid cyst in toto by a sharp dissection. You coagulate the feeding vessels. Always you'll have the choroid plexus attached and you'll have a feeding vessel. So this is a removal in toto. And then you can see the ventricle, it is clean. Third ventricle is clean. That's the patient post-op. So we used to do this endoscopically. I'll show you. But if you want to remove the cyst, you have to do it with a bimanual technique, as Sunil said. You got to use a deck system. That's the deck system which we use. But still it is difficult because you're continuously irrigating. Now, this is how we used to do it. But now I have given up and I prefer to use the transcallosal approach. So here we got a very good excision. Of course, 100% excision with an endoscope, even with the bimanual technique, or unless you use the dry technique, means you go with a sheath inside, collapse the ventricle just like a transcortical, and excise it with 2 hands. It is difficult to remove it completely. So we had removed this, but after 5 years, this patient came back with this colloid cyst. If you see here, the colloid cyst has recurred. So what we did is we went in through a virgin area. That is here we are putting Merocell to keep the brain and the hemisphere away. And if you see here, it is pretty adherent to the fornix. So here you have to do sharp dissection. And you have to have control with both your hands. So the wall is thickened and you can suck out the colloid. And you have to work preferably with a foot magnification. You cannot use your hand because you are already in a very deep zone. So use foot magnification, or you can use the mouth switch. I am more comfortable with the foot magnification, as you require a lot of magnification and you cannot afford to put your hands and bring your hands out and adjust the focus. So very important, foot magnification. So here is the whole cyst coming out, and finally we were convinced that we had removed this completely. And if you see the floor of the ventricle, third ventricle, it is clean, not a single spot. When we do endoscopy, even we used to find there will be a lot of petechial hemorrhages around because of the handling of the sheath. The sheath cannot be seen through the scope. You can only see the scope. So that's the patient post-op. Now this is a patient who we had operated for a subdural hematoma around 20 years back. He came with a colloid cyst. So now it was with a catch-22 situation, how to operate this patient. We could not go transcortical because there would be a lot of adhesions here. So we went in transcallosal, but mind you, the corpus callosum was not that easy to handle. Oh. So this was, I'll just go to the video. Okay. So that was the position. If you see, it doesn't have a bone flap on this side. So what we did is we did an extended craniotomy here. We localized it with and that's the vein. Sometimes you have veins like this. You do not coagulate. We're using something called as hemopatch, and we allow that there. We do not even dissect the dura there. You keep the dural sleeve over that vein. And here we are going a bit paracallosal. There is also an approach called a precuneous approach, where you can go into the third ventricle via a precuneous approach. So this is what we are doing, because it was difficult to reach the corpus callosum here. So we had to localize with the ultrasound and then use the paracallosal approach. And that is what you see. Follow the corpus callosum, a little bit of opening of the cyst wall here. It's a pretty adherent cyst wall. So we can suck out all the colloid first without it contaminating the ventricles to prevent chemical meningitis. Get the adherence of the corpus callosum out by sharp dissection. And then the last part can be coagulated and you can remove it completely. So no contamination of the whole ventricle with colloid material. We are doing a post-op ultrasound here. And this was the patient. He already had weakness 20 years back, but he did well after the surgery. This was a tough one because of the previous surgery. Now, this was a patient, a colloid cyst with a corpus callosum AVM. So the one option would be, because he had severe headache, we didn't know why the headache was, whether it was the AVM or whether it was the colloid cyst. But we decided since in the same trajectory, we'll go for the AVM first. If we succeed in doing well with the AVM, we would go in for the colloid cyst. So that is what we did here. A same transcallosal approach, identifying the pericallosal artery, getting the feeding arteries. Here we are using Merocell again, no retraction. Somehow retraction creates more problems. It decreases your working space. The ICG. That's the feeding artery and the feeding vein. So here to go through the corpus callosum, we have to get the AVM. It will be very difficult otherwise. Using a temporary clip. So if you one can use a handheld retractor if you want, but no self-retaining retraction. So we are taking down the last draining vein here. After putting a silver clip, we excise the AVM first. That's the AVM excise. And then one can go in the straight trajectory to open the corpus callosum and get the colloid cyst out, which is in the same trajectory. So you have to keep ready for transcortical also. So always plan the craniotomy in such a way that the transcortical is also ready for you. So that's the last part we are. So this part, the last part requires sharp dissection and cutting. Otherwise, you can't get it out. So this is after removal. And that's the post-op DSA, that's the patient, that's the post-op scan. So this was a large cyst. It was almost coming into the lateral horns, and it was tackled by transcallosal, transchoroidal approach. So we went transcallosal through the interphonic space and transchoroidal between the internal cerebral veins to get this whole lesion out, which was almost reaching the prepontine cistern. Again, no retractors. It was almost going to the prepontine cistern. So it was a large cyst. And if you see, when you don't have retractors, you have more place to put your instruments. You can gradually have a more control and always use foot magnification. Because once you have your retraction with your hand and with your bipolar, it's very difficult to control the focus. Here you are seeing the PCA, the SCA posteriorly. And that's after removal of the tumor, a complete closure. That's post-op scan. That is the patient. So complications do occur in all types of cases. Here you have to be worried. The most common complication and the most dreadful complication is a venous injury, which occurs when you're retracting. So if you see here, we had one patient whom we operated transcallosal and one vein gave way, and see what happened. It was a hemorrhagic infarct. We had to go back, remove the bone flap, and then he had a rocky post-op recovery. He had weakness on one side, and then he recovered to this level now. So you have to be worried about a vein. Never coagulate a vein, preferably avoid coagulation. Go a little bit anterior if you require, if the vein is in the way. So these are the difficulties which can occur, and one has to be totally focused when you're operating on these patients. And if you have too many bridging veins, then you have to change course and go transcortical. Always have a plan B. So these are elegant tumors to operate, but you can get into severe complications if you do not plan these surgeries. For me, the use of the microscope is, it has to be, it is godly. And endoscope, I do not use anymore now for excision of colloid cysts. Thank you, and sorry for the hitches initially. So, stay.
Thank you, sir, for the wonderful presentation. Like one after another series of beautiful videos. Kishore sir, Sunil sir, any comments on transcallosal approaches to colloid cyst?
Sorry, Sunil, go ahead.
I agree with what Varnan says that the trans-callosal approach is a more elegant approach and can be used even in the absence of hydrocephalus, right? And you're not going through any cortex, so I think the risk of cortical injury is less, but you are going to encounter other structures also. So I think with training, you have to decide what works for you best.
Kishore sir?
That was very nice presentation, Varnan. But I beg to differ a couple of things. I think that's a bit of a misconception that self-retaining retractors will cause harm. Actually, self-retaining retractor, if used judicially, I think can be a very good asset, and that can free up your one hand if you're using a handheld retractor. And I've never found the need to use a foot magnification or focusing system. I think I'm very comfortable using both hands with self-retaining retraction with very minimal damage to cortical veins. The difficulty comes with self-retaining retractor if we inadvertently lean on the retractor blade or the arm, and that can happen very easily. Or if an assistant or a nurse can touch it sometimes and cause damage to the cortex or the vein. Otherwise, I think self-retaining retractor in most hands who are doing microscopic surgery should be reasonably safe and would not need to use retraction. It is just to protect. Other thing I find is that superior sagittal sinus complications are inevitable in some cases if you're doing transcallosal, not only for colloid cyst. For that is a big advantage of having a transcortical, transventricular approach, that the superior sagittal sinus is kept away. And it will be very unfortunate if someone has a venous infarct going through a right frontal transcortical approach. At least I have not had any or I have not seen any. But I agree, I think all the three presentations are very superb and they all make very convincing cases for you doing their respective approaches. And if I get a case next time, I would be I would struggle to decide which one is the best because I happen to be convinced about using all the three approaches now. So congratulations to all the three speakers. I think that was a very excellent presentation and moderation, Chandan, of course.
Thank
you. So one question, Subodh sir, do you, so Varnan sir made some points, made strong points in favor of transcallosal, but some points against endoscopy. So do you have any, did you have a different perspective on that or?
No, it's not the question of different perspective. The perspective is correct what Dr. Varnan told. I told you, and my last statement was the best thing is done what you can do best, in which you can produce the best results. And the small thing is that a transcallosal is better than transcortical. I don't agree with that point. Both are equally good. Okay, as I told you, some of these higher mental functions and the couple of small studies which are available, which tell, because the transcortical we are going through the SLF and then directly into the ventricle, and it's wrong that the transcortical will cause higher mental function disorders. Okay, and about that, one more point regarding that incomplete excision. Yes, I think that a transcallosal gives you a complete excision better. Because you are directly into this, and endoscopic may be bad, but yes, if you are able to do a bimanual technique and you have a armament with the flexible endoscope, you can see the roof of the third ventricle. We can achieve with more and more evaluation techniques and instruments available.
So
Can I-
one question. Yes, yes.
Sorry, can I ask a question, Chandan?
Sure.
To the for the endoscopic approach, I've seen that most endoscopic prefer to do a septostomy at the same time. And why would that be? Is that really shouldn't be necessary? And second thing is that I used to put an external ventricular drain prophylactically for 48 hours, but I used to keep it closed. Nowadays, in last 5-6 years, if the surgery has been very clean and there is no blood in the ventricles, and I do not keep a drain at all. Really, I think keeping a drain can be life saving, but at the same time can also lead to complications. So, any thoughts about this for any of the surgeons? Also, Abhay Kumar wants to know about our experiences regarding memory disturbances in unilateral fornicial damages. So I'll leave it to the speakers to talk about these as well.
Varnan sir, would you like to answer about memory disturbances
Yeah,
and
see,
fornicial injury?
I would be more worried about handling the phonics. Okay, I wouldn't be worried about handling the corpus callosum. The corpus callosum, you do not go more than 2 centimeters. You have seen in the videos where you just open it enough, and once the ventricle goes down, okay, you have enough of space to enter and do your job. So the memory damage occurs with all 3 procedures. Understood? It can happen with endoscopy because you are not seeing the sheath. And many times this is what used to happen to us. Okay. I would say we used to have more memory disturbances because you cannot see the sheath when you're moving it. You can only see the endoscope at the end. The end view you can see. And many times you will see these small pedicle hemorrhages which occur. When you irrigate and then you got to keep on irrigating, you will see that. Comparatively, you can handle the phonics better when you're doing a transcallosal approach because you're going straight for the cyst, you're aspirating the cyst first, you're getting it off the colloid, and then you're getting the whole cyst out, okay, by a gradual manipulation. That is one. The second thing is what Dr. Kishore pointed out is there can never be a complete clean surgery in colloid cyst. Moment you puncture the cyst, there is going to be some colloid coming out of that cyst and entering into the ventricle. You can't avoid that. However much you try to suck with any other procedure, all 3 procedures. But the cyst contamination of colloid is lesser when you go open it a little bit and then suck out the colloid completely. So, but I still prefer to keep a drain because I have burnt my fingers. That is why. So I prefer to keep a drain for at least 48 hours, okay, and remove it after that.
The reason for keeping the drain?
One is chemical meningitis, lot of colloid which can irritate. Second is bleeding. You can get a bleed which can cause sudden acute hydrocephalus and kill the patient.
Existing blood clot or a fresh bleeding?
Fresh bleeding.
My reason for doing a septostomy is that to inspect the opposite side actually. Because as we know, this opposite side is a blind. So I always do a septostomy and just have a visual inspection.
Yeah, I think that's a very valid point.
Okay.
What I was saying, sorry, about the keeping the drain is that if you think the cyst content have not spilled in the ventricles and there is no hemorrhage, then I'm done away with keeping the drain. If there has been some hemorrhage and if you feel that there is a residue of blood clot in the ventricle, or if the contents of the cyst while aspirating have spilled, then I don't disagree with keeping the drain. But this is just a thought. I'm not saying there is anything right or wrong. I think at the end of the day, the surgeon has to take a call. And if in doubt, I think it's always preferable to keep an EVD closed for 48 hours. Would you? I think everyone would agree with that, probably.
Yes.
Yeah.
Sunil sir, you had a comment?
This is not
Final
about
comments?
surgery. This is more about colloid cyst. And the question I have for all the panelists is, what advice do they give asymptomatic people with incidentally discovered colloid cysts?
Yeah, that's a good question. Shiv Shankar, why we start with you and then go to other speakers? Asymptomatic colloid cyst, incidentally detected. Is there any a plan of management?
Most of the time when the patient presents, and most of the patients with the headache, they ask for scans. They want to get the scan done so that they want to be clear with anything is not in the brain. And we happen to see many such incident lesions in the brain, and colloid cyst we often see. And when the cyst size, I think Dr. Subodh Raju sir showed on the slide, and the cyst size will decide, and its relation to the Monroe, that will decide about the need of surgery. And if there's a small cyst which is not obstructing the form of Monroe, and then I don't think they require surgery, and we keep them in follow-up, and we advise them about the red flag signs, that any headache, vomiting, or sometimes the hydrocephalic attack, the relatives take it as a seizures, and even the general practitioners. And any such things happen, it's a very rare possibility. We ask them to come back and get evaluated, and serial scans we do with an interval of 6 months, and then take a call.
Subodh sir, I think you showed the CCRS score also.
Yeah, colloid cyst size less than 7 millimeter, age more than 65 years, presence of headache, flare hyperintensity, and the risk zone. It's a fair tool if you keep it in the OPD for all practical purposes to decide about this thing, decide about the whether you should intervene or not. And Dr. Varner also told about that less than 1 centimeter we can observe. Without asymptomatic less than 1 centimeter, we can observe actually for all practical purposes. And listen, the posterior lying cysts which are high riding, high urban the thing, they are relatively safer. The cysts near the foramen of Monroe, they are the more dangerous ones.
Okay. So, any
Chandan,
final comments?
Yeah, may I ask a question to all the panelists? If you have
Yes,
an
sir. Last
elderly
question.
gentleman, elderly gentleman with the normal pressure hydrocephalus-like symptoms and a presence of a colloid cyst, which may or may not be symptomatic, what would be your approach if the patient is say, fit and 82 years old? Would you just do a shunt? Would you just observe? Or would you use any of the 3 techniques and exercise and venture to excise the cyst? So, over to you guys.
Varnan sir?
I would go for a CSF diversion, a pressure regulated shunt or something like that, which would be the best for him. If you said if he's already having, NPH like features. So that would be my take on it. If the patient is 82 years old, it's not going to be easy doing surgery in him, especially the brain. Sometimes the dura is stuck, becomes difficult to operate these patients. Okay, so the less you do, the better for him, in my opinion.
Fair enough.
If the cyst is obstructing at the foramen of Monroe, I will just do an endoscopy, evacuate the cyst content, and put a shunt and come out.
Okay.
And would you do the same, Shivashankar?
Sir, if the patient has been clinically proven by a neurologist that CSF drainage has resulted in improving his symptoms, and if he really requiring CSF diversion, if he's going to benefit with the CSF diversion, then I think at the same time as Dr. Subodh Raju pointed out, take out the cyst endoscopically and put the shunt and come out.
I think fair enough, but would there be a case of just incompletely evacuating cyst contents and then just wait and watch? This is one of the cases where you do not have to resect the entire cyst wall. If it's a symptomatic patient because of the colloid cyst, just aspirating the cyst content endoscopically would be probably the most minimalistic yet effective procedure, wouldn't it?
So if
No,
it is
see,
NPH
aspirating the cyst, Kishore, there are high chances of chemical meningitis. Okay, you either go for the cyst completely, or you do not touch the cyst, in my opinion.
Yeah, I'm just being devil's advocate here.
I think we are short over time, and I would like to thank all the speakers, Dr. Shivshankar, Dr. Subodh sir, Dr. Vernon sir, for their superb
Yeah, sorry for the hitch.
presentations.
Sorry for the hitch. I had to change 3 laptops, and I also like to thank my army who is here with all their laptops. My all lecturers have come here with 3-4 laptops, and that's why we could do the presentation. Thanks for your
Yeah,
patience.
so your superb videos made up for it, sir. So it was worth it.
Thank you.
Thank you, thank you, Kishore sir.
I'd like
Thank
to
you,
thank my
Sunil sir.
residents for that. They do the videos. Yeah, and the lecturers. Yeah.
Thank you, Sunil sir, and Katikar sir. And we will now close this webinar for today, if Katikar sir permits. Thank you very much. Good night, everybody.
Thank you, MCNS, for the opportunity. And
Thank you, sir. Thank you very much.
Thank you.
Yeah, thank you and hope to see you in the next webinar. Thank you.
Thank you.